general, there's just several topics within this area, but I just chose very specific ones that are very interesting. And then when I was reviewing actually this every single topic, I found so many interesting stuff that I hope is interesting to you as well. So the objectives of these lectures are pretty much this ones. Number one is, what are the real risks about doing a thoracentesis? There's many things that you can find in the literature, and not many of them are actually backed up by good evidence. So we're going to go over every single one. Then talking about the intercostal artery, that's actually our biggest fear whenever we do a thoracentesis, whenever you want to get a pleural effusion. What are the real risks about hitting this intercostal artery? Then this old concept, pleural elastance and manometry use. This is very physiological. It's actually boards material too, and it's very controversial too. A fourth thing is, talking about pleural effusions, so talking about the Lice criteria. I'm not going to go too basic, but most on the origin of the Lice criteria and the challenges that nowadays we have, and then ended up on some of the new studies that are going on pleural effusion, meaning not talking about biomarkers. So whenever you have a patient with a pleural effusion, you need to tell the patient, hey, you're going to have a thoracentesis, pretty much, right? And then your patient most likely is going to have a million questions about what does that mean to have a needle on my back. And the biggest thing that you need to get before doing this procedure is trying to get, number one, informed consent. In order to get an informed consent, you need to talk to your patient about what are the real risks about doing this very benign, supposed to be procedure, which is not a procedure that just pulmonologists do. Internal medicine does it, IR does it, any other critical care physician does it, but I'm guessing whenever there is a specific question about thoracentesis, everybody's gonna ask us. So better we know about it. So common sense, we've been told in medical school what are pretty much the risks about doing a thoracentesis, and we all maybe did a thoracentesis in the past. So it's just common sense. It's just number one, infection, maybe blood, bleeding, maybe a pneumo, and this concept, responsive pulmonary edema, which is very controversial too. And we're going to go over every single one. So let's start with bleeding. This is a really nice guideline that I recommend whenever I have kind of a question about pleural effusion or anything related to the pleura. I just go to this guideline, which is the most comprehensive one. They have everything there, everything related to the pleura, chest tubes, empyema, pneumothorax, everything, it's there. So number one, you want to talk about the risk of bleeding to your patient who's about to have a thoracentesis. And what these guidelines tells you is that you are supposed to have an INR lower than 1.5. This is the recommendation by the British Thoracic Society guidelines in order to proceed with a thoracentesis, a non-urgent one. Now, if you take a look, it has a level of evidence of C. So you get a little bit suspicious about what is the real evidence behind this recommendation. Then, this is just a personal thing. Whenever I do procedures in the ICU, I always take a look at these guidelines. These are the Interventional Radiology Society guidelines for procedures. And they go over every single procedure that they do, which are pretty much the same ones that we do in the ICU, just to talk about it. But taking a better look on these guidelines, you can find that at the beginning they mention that there is not much evidence about every single thing they're going to say, and they go over the Delphi consensus. And I think I talked about the Delphi consensus before because the pneumothorax guidelines from ACCP, they actually apply this concept. What is a Delphi consensus? So pretty much they have an expert panels, and this is because there's no such good evidence to just make a recommendation just like that. So they need experts. They send them cases, they send them questions about this specific thing that they want to put on paper, and then they receive feedback all anonymously, and then they make a recommendation. That's how they build the guidelines. These ones that I just told you. So these guidelines, they put thoracentesis as a procedure that has a low risk of bleeding. That's okay. But again, if you take a look, the management that they would prefer for these patients to have before having a thora, it's to have an INR lower than 2 and platelets higher than 50,000. So now you have two different guidelines telling you kind of the same thing, that you're supposed to have a very low INR in order to proceed with this procedure. Sometimes we have to do it in the ICU to many of our patients that may not be the perfect candidate. But that's what they told you in 2010, that's what they told you in 2012. we can go over actually about the newer evidence behind this thing. And this is an article from 2013 done by Dr. Puchalski. This is from Yale University, and this is a prospective study. So what they did is they had 254 patients that they started doing thoracentesis, a prospective study. And they divided the patients in between patients with a bleeding risk and patients with no bleeding risk. So 130 had a bleeding risk, and very legit bleeding risk if you take a look. So there is a specific amount of patients that had low platelets, specific amount of patients who had an INR more than 1.5, patients on Plavix, patients on heparin, and patients with renal disease. Now, as you can see, it's pretty decent the amount of patients that they had, and they just did it. They didn't include any patient that had the heparin stopped, for example, or had the Plavix stopped, for example, or that they stopped the warfarin. Those patients with those criteria, they just did the thora. And what the main goal that they had was three things. Number one, how the hematocrit, and pay attention to that, it's just the hematocrit. We're not talking about hemoglobin here. They took a look at how much it would change the hematocrit pre and post procedure, 24 hours after doing this procedure. Number two, death. And number three, any changes on the x-ray, meaning possibly a hemothorax. So taking a look at those patients, there is not that much of a difference. Actually, this is not significant. There is no such difference if you just take a look at the hematocrit. And if your question would be, then what about every single specific bleeding risk? You can see that it's not that significant anyway. I mean, the highest one is minus 1.1, and this divided in between 3, it's going to be lower than 0.3 for hemoglobin. Now, the good thing about this study, I know it's very low numbers, it's not a huge study, but it's the only prospective study talking about this specific question, meaning the bleeding risk on patients that are undergoing thoracentesis, and it does correlate with prior retrospective data. The whole data that we have about this specific question is all retrospective studies, and they are agree with them. As I told you, there is some other objectives that they had, meaning if there was any X-ray abnormalities, and there wasn't any at all for those patients. Problem with this study is a single center study. It was just done in Yale. There is no randomization whatsoever, and there is a selection bias, of course. Here's the problem. They were just, all those patients got referred to this specific team who did this thora. So they have the question that maybe those patients that were referred to them were not the high-risk patients. And those high-risk patients, supposed to be, they were just never sent. Or maybe they didn't have the procedure done. And the other problem is that they didn't take a look at hematomas. I mean, there wasn't change of hematocrit, there wasn't any single death, there wasn't any change on the X-ray, but they don't know what happened to the subcutaneous tissue. They never check on that. Did that happen? We don't know. Now, this is one. Now, this is an interesting study from LA. In this hospital, which I'm guessing is Cedars-Sinai, they have a proceduralist team. So they do all the procedures, including thoracentesis. So they took a look as a quality test or as a quality study that actually was done by Northwestern over what it was done in LA. And they wanted to see what happened to those thoras that were done over 12 years. So now we have bigger numbers. We're talking about 9,000 thoras that was done by this team. And just focus on the bleeding risk, it's just 17 people who ended up having some bleeding. And the real risk is actually 0.18%, the incidence of having a bleed. We're going to go over every single one, but just focus on the bleeding right now. The thing with this study is that even though there were 17 patients that bled, they interestingly put there in the article that there was no association whatsoever on those patients who bled, meaning those 17 ones, with the INR, PTT, or platelet count. Actually, I took a look at it, and they even did a thora on 55 patients with platelets lower than 20,000. The problem with this study is that according to them, which is very hard to believe, but according to them, over those 12-year span, meaning those 9,000 thoracentesis, the only one who did this procedure was just one physician. So this physician apparently did these 9,000 procedures, and there could be some sort of bias here, because whoever make the possible complications for every single procedure was exactly the same physician. So that's number one. And number two, they just look into 24-hour complications, which makes sense, but there might be a possibility that some other complications may happen later on. Now, what's behind all this? I mean, behind the hemothorax, behind everything that could relate to bleeding, I think our biggest concern is just the intercostal artery. And this is how we've been told how the intercostal artery runs, and we're pretty aware about it. And that's why there is a whole controversy about it. It's not like the paracentesis. In paracentesis, the evidence is a little bit more clear because there is no arteries running. And that's why you just don't correct it, you just do it. There is no such a problem. With thoracentesis, that's our main concern. We all know that it's supposed to be just inferior, so that's why you do a thoracentesis just touching the rib and then you go higher. Every person does it differently. But what happens if I tell you that this might not be real? What happened in this patient? There are some data already that showing that patients who tend to, elderly patients, tend to have this kind of variation in the intercostal artery. And this is a true example on a patient who's 80 plus years old. Now, what's behind this? It's this very interesting study. It's a very small study. They just did 33 patients who had CT angiograms, and they took a look at how the intercostal artery was running, the anatomy pretty much. This is how they did the study. So this is the spine, and then they took a look at how the intercostal artery was running on a medial side, meaning in between 5 to 6 centimeters, then on a lateral side, meaning in between 10 to 9 centimeters from the spine, and then a total side. Now, the concept that they make, which actually has been apparently validated in some previous study, is the percent safe space, meaning the distance in between the intercostal artery and the rib divided by the whole space in the intercostal artery. So the numbers are very interesting because taking a look at what they did for those 33 patients only, all above 60 years old who had angiograms consecutively, is that apparently 79%, there was a percent of safe space, 79% more laterally compared to medially. And this was significant. This is just one study. Now, then you come and then you say, okay, there is so many questions here because I've been doing thoracentesis the way I've been told, this way. And as you can see, they recommend to do it in between 5 to 10. So maybe shouldn't be doing it there. Maybe we should be a little bit more lateral in between 8 to 9, maybe. But then you say, hey, but what happens if I have a very posterior lobulation? Then what happens if I have some body habitus? Patients, it's very difficult to position them sometimes. Well, maybe this could be the answer. Maybe. This is a study done in 2011, and what they look at is how to identify the intercostal artery by ultrasound, which didn't look too difficult, to be sincere, to me. And let me tell you why. So they went over 4 points, kind of the same concept, meaning from the spine till the medial aspect. And then they were just doing vascular ultrasounds. It may not look that clear here, but taking a look here, this is the rib, this is the other rib, and this is the vessel. Not that different from what we regularly do for putting central lines. So kind of the same concept. They wanted to see how much distance was in between the rib and intercostal artery divided by the whole intercostal space. Here's the results. So as you were going laterally, it was supposed to be safer. The intercostal artery was actually closer to the rib as you were going laterally. Now, based on those two studies, actually there is way many more, but those are the most interesting ones that I found. If you go back and take a look at the guidelines from BTS, what they recommend for patients to have a thoracentesis is still to do it on the medial aspect. Now you have so many questions, I had them too. What I can tell you is that current practices, according to these guidelines, may not reflect true evidence-based medicine so far. Those studies that I told you about might not be included whenever they build those guidelines. Number two is that thoracentesis might be a very safe procedure, and the only thing I am 100% sure is that there is no absolute contraindications to do a thoracentesis for the bleeding aspect only. And that maybe vascular ultrasound incorporation on a very selected population, meaning those patients who are elderly, meaning those patients who are critically ill, and maybe a hemothorax would be a disaster, that you have to go posterior, maybe incorporating, taking a look at the vascular access right there, taking a look at your intercostal artery, not to hit it, might be okay. There's no studies about it. I'm just making this up based on what I saw. Now, we'll just talk about the bleeding. Let's talk about infection now. This is a study from Mayo. So this is from the IR service. And they wanted to see, as a quality study again, what happened to all the patients that they had with a thoracentesis in the past. And there are good numbers here. More than 2,400 thoracentesis. And the rate of infections was 0. No patient had any infection whatsoever. Now, the problem with this study is that they just took a look at cultures that were only requested by the physician depending on whatever suspicion they had for an infection. It doesn't include cellulitis, so we don't know what's going on with those patients. But none of these patients had any admission for an infection, and none of these patients had any positive culture. That I can tell you. So then you come to the question that maybe should we ask for that kind of risk on your informed consent before doing a thoracentesis? Maybe we shouldn't. Maybe, according to this study, there is just no such risk. Now, talking about pneumothorax, I mean, it's pretty well known. Sorry,
that doesn't make sense.
Why?
You cap them at the time of doing the procedure, they're not going to be infected. You're infected after the procedure. So how can they go by the cultures based on?
So those cultures were done afterwards, based on whatever the physician was taking care of that patient, thought was going on afterwards. Let's say the patient had a thora, 2 days later, the patient had a fever.
Okay.
So if the physician felt that this fever was secondary to something else, they just treat the patient and wasn't considered. But if they felt, the physician felt there could be a chance that it was secondary to the thora, then cultures were done, cultures positive, okay, it's secondary to the thora.
So they went and did another tap?
Blood cultures.
Tap?
Blood cultures.
Oh, blood cultures.
Blood cultures only. So that's the problem. Now, talking about pneumothorax, it's pretty well known what the risks are about doing this kind of procedure for this to happen. Now, we all know that we are supposed to use the ultrasound, and this is backed up by so much evidence already. Using the ultrasound, you can lower your risk. It can be as high as 30% if you don't use an ultrasound, and it can be as low as 6% if you do use it. But the real question is not about, the overall population. The real question to me is that what happened on this population? Patients who are vented, patients who are critically ill, patients who are in the unit that you need to do a thora. On who do you think, if the pneumothorax happened, then this can be, again, a disaster. So this is a meta-analysis. They went over how thoracentesis went only on ventilated patients. So it kind of applies. It was 19 studies, more than 1,000 patients under mechanical ventilation. But the problem that I had with this study is that there is no data whatsoever on hemodynamics or if the patients were on pressors. The patients were just vented. That's the only thing we know. And obviously they were in the ICU. So the pneumothorax risk was about 3.4%, and the hemothorax risk was 1.6%. Now, talking about patients on pressors, I think this study might give us an answer. This is from 2004. And what they did is just thoracentesis on patients mechanically vented, kind of the same idea. It was 232 thorax. 90 of them were diagnostic, 142 therapeutic, and it's not very clear to me why they were doing therapeutic thoracentesis, to be sincere. But anyway, the PaO2 FiO2 ratio was the mean 178, PEEP of 6.8 for those patients. And there was a significant amount of patients that were on pressors. How much were they using? We don't know. It's not there in the data. But it was a significant amount. Now, the risk for pneumothorax was only on 3 cases. Only 3 cases out of the 232 patients had a pneumo. And even if you include only those patients on vasopressors, it wouldn't be that high. let's say that only the patients who had a pneumo are the patients who were so critically ill that were on pressors. And why is not that high? Because if you compare it with the previous study that I showed you, the numbers do not differ that much. I mean, we have 9,000 patients. We have patients with pneumothorax, which was 0.61%. Yeah, it's a little bit higher, but I don't know it's significant enough to say, hey, if your patient is on pressors, if your patient is critically ill, maybe doing a thora might not be a good idea.
Hey, Alex, in these studies, is the standard to use ultrasound in each one of them?
All of them. Every single study that I'm going to present today.
Can you go to the previous slide? It's 2011, I'm sorry.
Yeah.
2011.
All of the studies that I'm going to present, specifically for pneumothorax, all of them were done under ultrasound. None of them was done without using the ultrasound.
Did any of them have tension? Of the 3 patients?
No, nobody died. And there was no hemodynamic compromise, according to them. Just in one line. Now, the responsion pulmonary edema, I think this is the most controversial topic, and this is one of the things that we all have a question about, because the incidence is very, very variable. The incidence goes between 0.1% till 30%. The mortality could be as high as 20%, and this is not only exclusive for pleural effusion. It could happen actually on pneumothorax too. And the management is all supportive. So there is a lot of things going on about this entity that I haven't ever seen, but apparently it has a really high mortality risk. Now, on your own experience, how much do you take out on a regular thora?
1.5.
1.5, right? That's what we've been told. But then why?
Expansion pulmonary edema.
Here's this concept. In the pleural space, you're supposed to have a negative pressure, supposed to be in between -3 to -5. And this is because of the elastic recoil from the lung compared to the chest wall. That's how this negative pressure happens. And yes, we've been told this thing many times. You're not supposed to go any higher than 1 to 1.5 liters. Why does that happen? Well, I took a look at the literature and everything starts here. In a 1980 study done by Dr. Light, published in what it was the Blue Journal. You're not going to find this journal anymore. This, the Blue Journal was actually began as an American Review of Respiratory Disease.
No, it actually began as American Journal of Tuberculosis.
There you go.
I assume that's 80.
Anyway, so this is what Dr. Light came with this study. He did this study and he found out, I don't think he built this concept of pleural elastance. I think that was already previously done. But what he put on this study is these curves that actually are boards material. You're going to see these curves many, many times. And what it is, pleural elastance, it is the differences or the relationship in between the pressure and the volume on the pleural space, how much volume you take out during a thora. As I told you, because of the elastic recoils, your pleural pressure is supposed to be always negative. However, as you start building up fluid there, it's going to start becoming positive. So the first curve, which is supposed to be normal pleural elastance, happens regularly on heart failure patients that you're doing thorax, or happens on hepatic hydrothorax. So your initial opening pressure is going to be positive. So that's 10. And then you can remove as much fluid you want, and then your pressure, your gradient, is not going to be that high. This doesn't happen on other entities, meaning trapped lung or entrapped lung. That's what he found now doing this physiological study. This is how he did it. He used just a single manometer. He used the famous Abram needle. But here's the problem with this study. What he did is like he never went more than -20 of pressure. Once he found out that the pressure was dropping to -20 using the manometer on that pleural space, he stopped. And then your question is going to be, why did he stop? And I look at it, and the only way that he came up with that idea was based on this study only. This is a study published a few years before that study came out from Dr. Light. Yes, this study was done on rabbits. So what he did is, this study, what they did is pretty much they had maybe 40 rabbits, This is from anesthesiologists, this study. They intubated them. They put some air, they instilled air, like 80 mLs or so. They kept them intubated plus a pneumo for 8 days or so. And they wanted to see what the risks are about having responsive pulmonary edema with some pressure. And these are the results. So the way they figure the percentage of edematous lungs is because they put all these rabbits, they had some pressure, and then they killed them, and then they took the lungs, they sliced them, and they come up with the percentage of edematous lungs. And that's how they make up a concept of responsive pulmonary edema. And as you can see, it starts going up by minus 20 torr, which is 27 centimeters of water. This is the whole idea why Dr. Light on that previous study didn't go any lower than minus 20 centimeters of water. Yes, it was an arbitrary number based on this study, because this study was showing that on rabbits, if you were going above 27 centimeters of water, patients may have a risk to have edematous lungs, meaning possibly responsive pulmonary edema. Why don't we choose a lower number? So that's why he arbitrarily chose 20 centimeters of water. But this doesn't respond still the question about why 1 liter. Well, it's because of this. Because on that same article, what he recommended that if you're not using a manometer, then don't go any further than 1 liter. And ever since then, since 1980, we've been just doing this based on all those previous studies only. Now let's take a look what's going on right now. This is a study from Hopkins. So what they did was just large volume thoracentesis on everyone, and just figured out what the real risks are for responsive pulmonary edema, kind of disregarding those previous studies that I showed you, and kind of disregarding what we're really being told to do, and what the current practice it is, and what the guidelines even tell you to do. The thing is that they respected somehow some of the things that Dr. Light was saying before, meaning not going any lower than minus 20 centimeters of water. Meaning, if the patient was going any lower than minus 20, they were stopping. If there was no fluid, obviously, they were stopping. If there was any chest discomfort, they were stopping. And it was not documented in some of them. So they had 185 patients that they went all the way. They just removed all the fluid that they could. So 185 patients, 1 liter was the minimum they got. The mean volume was 6 liters. The maximum volume, I'm sorry. The mean volume was 1.6. And there was only 1 case of responsive pulmonary edema out of 185 patients. The thing is that this only case that had responsive pulmonary edema, the volume removed wasn't even that much, was 1.4 liters. So, and they were doing some x-rays on some of them. We don't know why they did them, because not everyone who had this thoracentesis, this large volume thorax, had an x-ray. They didn't. But apparently there were 4 patients who had some radiographical changes compatible with responsive pulmonary edema, but I don't know what that means. What I know is that only 1 case had responsive pulmonary edema. Now, taking a look back, they had at least 28 patients that went a little bit lower than minus 20 centimeters of water. And guess what? None of those 28 patients had responsive pulmonary edema. It's still very small numbers, but you can say that maybe this is wrong. Maybe what we've been doing is not what is true. Now, there's some other physiological studies that tell you that the pleural and the pressure on the pleural space whenever you take a deep breath can go as low as minus 30, and that's just normal physiology. The way this study has been done, this previous one, large thoracentesis on Hopkins, they didn't use those bottles that you can see right there. What they use is just the way we do it nowadays, just with the syringe. Why is that? Because they think, and this is true, that the pressure on those bottles is very seriously high. It can go as high as 1,000 centimeters of water. That's what the company that makes them says. Now, in Ford, the suction can go as high as 300 centimeters of water too. So that's why then they say that maybe a safer way to do it is just doing it 1 by 1 using the syringe.
Go ahead, type
There's a long afternoon.
What I can tell you, based on this data, is that expansion pulmonary edema is a rare entity, definitely, that it may be independent of how much fluid you remove. So maybe doing this conservative approach of doing just 1 liter or 1.5 liter might not be the right thing to do. And doesn't matter, even if you take a look at the pleural elastance, even if you take a look at the pleural pressures, there is no such evidence based on these studies. So, but this was just one study from Dr. Light, and that's not his biggest contribution. We all know that the Light's criteria is actually his biggest contribution to humanity, and this is, go ahead.
Sorry. How much pressure is created when you use a serum?
I don't know. They feel that once you do a thora and then you put this bottle in, it's going to take a long time for you to realize, okay, the patient's having some chest discomfort or the pressures are getting lower, for you to discontinue that. And in the meantime, you have 1,000 centimeters of water pulling some fluid, which doesn't happen with a syringe. Patients having some cough or discomfort, just stop.
Let me ask you a question here, too. There was an article floating around about 15, 20 years ago that gave the theory that the reason you get re-expansion wasn't so much due to the negative pleural pressure. It's more because you're creating increased pulmonary vascular volume. And for that reason, based on a few case studies, like I said way back when, they said, well, maybe because those patients have higher intravascular volumes or higher wedge pressures, that makes them more predisposed to leakage in that. Did you come across anything? Because I haven't heard that in 15 years.
Pathophysiology about responsive pulmonary edema, and I read it in many of those articles, it's not very clear. I have another theory. That they say is that maybe this atelectatic lung that has been just there for quite a while, it kind of concentrates some kind of pro-inflammatory that by the time you remove all that fluid, then all those things are released. And that's how you ended up having some responsive pulmonary edema. So I'm guessing because it's such a rare entity, there is not that much evidence about it, about what the real pathophysiology is behind that.
Is there a difference in the pressure in hydrostatic fluid, oncotic fluid, or inflammatory, given its control percent volume?
Yeah.
I was thinking maybe that like the incidence of expansion pulmonary edema depends on what you have. Hydrostatic or IMR.
It might depend on what, on the reason, the type of effusion. Very interesting theories, and you're going to find many other different ones, but there is no studies. There is just no evidence.
Have you seen all those the re-expansion pulmonary edema? Have you seen post-op patients that are getting extubated and taking a deep breath against the close? There's some reports of just even having re-expansion pulmonary edema.
On those ones, yeah. Yeah, that's true. That's true. No, I don't know. I didn't come across those ones. But yeah, I read the same thing at some point, yeah.
It's funny here, Paul and I are talking back and forth here, 20 years that we were doing these, think nothing about taking out 2.5, 3 liters of stuff. He said, "Did you ever see one?" He says, "No." I said, "I never saw one either." So,
I was talking to you about it, and that's what happens. That's what happens. I'm gonna tell you later the discussion that I had with Dr. Diaz about it, because everybody's so concerned about the fact that how to give a better patient care, meaning on the sense that why don't just remove 5 to 6 liters and avoid the patient having another thora later on. If you're so concerned about responsive pulmonary edema, then you're supposed not to do more than 1 liter. But then the real question might not be pulling all the fluid out. The real question should be, why is this patient having that much accumulation? And if the patient is going to reaccumulate, and you think the patient is going to reaccumulate, why don't you fix that thing? Meaning, if it's heart failure, meaning if it's hepatic hydrothorax, then you fix the liver. Meaning that if you don't know, then the patient should go by fluoroscopy and figure it out.
He's probably going to breathe better with an edematous lung than a totally collapsed one.
And this was a discussion that I had with him, and he was like, "What's better? What's better for you?" I mean, yeah, they might feel better, but then at the end of the day, are you resolving the problem?
Right.
You're just putting patches right there. Anyhow, this is the very first article, 1972. Dr. Light was the one. At that point, he knew, like back in the 1970s, 1969, that he was a resident. he figured that, yeah, they were taking a look at the pleural fluid on every single patient who had a pleural effusion. He knew that they were taking a look at the LDH because there were some studies mostly related to tuberculosis at that point. That he knew that maybe the proteins, if they were going higher, this might look like an exudate, but he couldn't get a specific, clear answer by whoever physician was running with him. So that's why he came up with the idea, why don't we get ratios? Why don't we get specific cutoffs, specific numbers? The only thing that was new before 1972 was that a protein level more than 3, it's compatible with an exudate. That's the only thing was new at that point. And that's why he recollected 150 patients. He did it prospectively. That's how this whole thing originated. With pleural effusions, they tapped the patients, and then what he wanted to do, and I wanted to be very clear about it because it's going to be very important later on, but what he wanted to achieve is not to differentiate exudates and transudates. What he wanted to achieve is not to miss an exudate. And that's how the Lyles criteria were built, not to miss exudates. And that's why he adjusted the cutoffs and the ratios just for that to be done. And I'm going to tell you why this thing is important. The interesting part about the Lyles criteria that when they were built, like in 1971, 1972, he proposed his study to the ATS and it was rejected. So that's why he presented this study to CHEST. He had an oral presentation. He said that it was kind of an average presentation, and then he ended up presenting his findings in annals. And that's how this whole thing started. Now, the problem that Lyles criteria have, and maybe that might be the question that you have, is what happens on those heart failure patients? What happens on those hepatic hydrothorax patients? Is that Lyles criteria is going to miss 30% of them, meaning that Lyles criteria is going to call your patient with heart failure, Lyles criteria is going to call your patient with hepatic hydrothorax as an exudate. So what happened with those 30%, which is a meaningful amount of patients? What Dr. Lyles says is that back in 1972, when he did his study, is number one, he didn't want to look for transudates. What he was looking for is exudates, and that's why he did those cutoffs. The second thing that he says on his defense is that back in the day, they were not using as powerful diuretics as we are using nowadays. Lasix was not a common thing to give. What they were doing, it's actually hydrochlorothiazide and mercurial chloride kind of diuretics. That's what he says. And he doesn't know, and actually he thinks that maybe those 150 patients that he originally studied, none of them were on diuretics. Now, why does that happen? This study, they wanted to take a look at how many of those patients are misclassified. So on the heart failure, you see same thing. 30% of patients were going to be misclassified as an exudate. On the hepatic hydrothorax, you're going to find 18% of patients that are going to be classified as an exudate. But they are truly transudates. We all know they are transudates. And actually in this study, they wanted to be 100% sure those were transudates, and they were. Nothing happened to them. This whole theory about the use of diuretics, it's kind of true because subsequent studies, for example, this is a very interesting one from Spain. What they did is that they had 21 patients with a pleural effusion that they wanted to tap. They tapped them every 48 hours, and the patients were okay with that, till there was no effusion whatsoever. At the same time, those patients were on high-dose Lasix, 40 to 80 IV, till there was no more effusion. And they were taking a look at every single marker, meaning proteins, LDH, and albumin. And as you can see, just by taking a look at that little chart, is that the numbers tend to get higher. Taking a look at the ratio, I can see clearly that there are some patients that now are going to be an exudate, just by taking a look at that number, and everything is significant, meaning patients in between the first thora and the final thora and their heavy diuresis, all of them heart failure, they were actually going very slowly to the exudate part. This is the number of misclassified. So again, you can see that by Lyles criteria, there is one just at the first one. The second one tends to get higher. And then by the third one, it's even higher. Now, just pay attention to the Lyles criteria and then take a look at this number. Then we have an albumin gradient. And even though there are some of them that are going to be misclassified, it tends to get a better number. Now, why does that happen? Well, this is all physiological, and there is just some minimal data about it. But the theory nowadays is that maybe albumin is the safest protein to figure it out if this is a truly exudate, because when you diurese somebody, the proteins are going to get higher, but the albumin not that much, because mostly the proteins that are there in the pleural effusion are non-albumin proteins. Now let's just move on. I mean, this was all 1970s. It's been 40 years since we've been using, more than 40 years since we've been using Lice criteria, and there hasn't been that much of a change ever since then. We're still using the same criteria, and they are great criteria because they are very easy to take. You just do a tab, and then you figure out this very easy test. It's very accurate, except for this transudate thing. And number 3 is very cheap. So. But the problem is that nowadays, after 40 years, even Dr. Light thinks that we have to move on. You can keep tweaking the numbers, you can keep making up some other stuff, but the real issue right now, the real challenge is not differentiating again in between transudates and exudates. What we need to look for now is real biomarkers. Now, biomarkers are supposed to have these 3 characteristics. It's supposed to be an easy test, it's supposed to be low cost, it's supposed to have clinical validity, and it's supposed to be useful. Now I'm going to talk about 3 different entities and some studies that are coming up, which I found very interesting. For heart failure, you have a distended ventricular wall, so then everybody knows that there's going to be some pro-BNP running. And then BNP is the one that is the active molecule. Then you're going to have some vasodilation. Everybody knows about it on heart failure. But there is another molecule. So pro-BNP divides in between BNP and NT-proBNP. The NT-proBNP, it has a higher lifespan, it's like more than 2 hours, and it's non-active at all. Now this study is from, no, it's not from Spain, it's a meta-analysis. They took a look on patients with pleural effusions of cardiac origin. They wanted to be 100% sure all of them were from cardiac origin, and they took a look at this molecule. So 10 studies there, kind of good numbers right there. And there was some misclassification by light criteria, as we already know that sometimes happen on patients with heart failure and their diuresis. But looking at the NT-proBNP, they were not that much disclassified. So taking a look at these numbers, sensitivity seems to be very high, specificity seems to be very high. It seems to be a wonderful test, because if you plot this thing by likelihood ratio, if you just have an idea that 20% of your patients, the pretest probability of 20% of patients with possibly heart failure and this pleural effusion to be secondary to heart failure, if you use NT-proBNP, it can go as high as 80, can go as low as 1 if it's negative. Sounds great, but the problem with this is that there is no blinding on any of those studies previously done. That may not be a generalizability about this study, because why would you do a thora on a patient who has heart failure, or you think that has heart failure? To begin with, you wouldn't do a thora. To begin with, you wouldn't do NT-proBNP. You would just diurese the patient and figure it out later on. There is no report on comorbidity if the patient had any other diseases. And the problem with all of these 10 studies is that there is a lot of heterogeneity there. The thresholds were totally different. Everybody chose a different threshold. So you can go as high as 2,000 or as low as 500 to call it positive for NT-proBNP. So it's there. It seems to be useful. It seems to be great, but it's not ready yet. So just you have an idea that this might be coming up later on in the future. Now the infection part, we all know these 2 patients have a pleural effusion, but now how can you differentiate if this is an infectious or not an infectious pleural effusion? Pancreatitis, it produces pleural effusion. Even a PE can produce a pleural effusion, and they both may have fevers, they both may have some constitutional symptoms. So how can you differentiate between one or the other? Well, this might be the answer, We all know what this is. We just use it for UAs. Well, they started using these things for pleural effusion and figured out this was infectious or wasn't infectious. So it's a very preliminary study. 128 patients, they divided the patients in between infectious causes for pleural effusion, tuberculosis, and non-infectious. And as you can see, there were none here, but there were some here, meaning that your specificity gets very, very high, 100%. Your sensitivity is low, obviously, just taking a look at these numbers, but your likelihood ratio is very high. Here's the problem. They didn't include any patients with any bloody fluids, because it makes sense, because if they were doing it, it's just going to be so biased because of the color. It's just a visual reader. It's a fast thing to do, but why wouldn't you do just a biochem on those patients? So they feel that maybe this could be the answer for low or resources limited kind of places where you don't have access to biochem, and just to get a very easy answer, just if your test is positive, is just by doing this thing, the dipstick strip. And the main question is not that. Maybe it's not just differentiating between infections and non-infectious, it's between a complicated and a non-complicated pleural effusion, because then it's going to change your management. Otherwise, it may not. Patients on antibiotics anyway. Then the third thing is tuberculosis. So I just put out this question, which is a real board question. So you have a 30-year-old guy with fever, cough. Patient has RA. He's on adalimumab, infliximab for 6 months. You have the X-ray. Gram stain, you have a negative, and the pleural fluid culture is totally negative. What do you think should be the next thing to be done? What's the confirmatory test for 2B? B? That's what I thought, but it's not. So when you are talking about tuberculosis, you need to do a culture, right? The problem with the culture is very low yield. It's going to be 15% of them are going to become positive if what you're thinking is tuberculosis. If you do AFBs, and it takes like 6 to 8 weeks to get it back. AFBs takes a few hours, but only 3% of them are going to be positive. Then the answer might be pleural biopsy, right? 80% of them are going to be positive if you are thinking about pleural tuberculosis. The problem with doing a biopsy is that it's some sort of a surgery, it's a procedure, so it's difficult to get. ADA might be the answer. So this is a study done on 2,100 patients. So they were taking a look at how the ADA was looking on those patients, and then looking back on what the etiology of the pleural effusion was. And as you can see, tuberculosis has the highest one, but it's not the only one who has an ADA positive. Malignancy has ADA positives, transudate has ADA positives, parapneumonic effusion has them. And if you want to be more specific, then you can even find that empyema has very, very high ADAs numbers. What this study concludes is that at the end of the day, your sensitivity and your specificity, yes, they are going to be really great, only on those patients that you restrict, meaning those patients with high pretest probability to have tuberculosis, have an exudate, and have lymphocytic predominance. Other than that, it might not be useful. So that's why this question, the answer is no ADA. It's pleural biopsy, because your patient is supposed to have rheumatoid arthritis. So then this whole thing is disbalanced. And that's it.